Okay, Paula, the floor is
Hi,
yours.
good day, everyone. Welcome to our Caribbean Climate and Health Workshop Series, Climate and Cancer, the third lecture in our series. And today is going to be quite exciting. Next slide. So I would just like to acknowledge my partners, the Global Consortium on Climate and Health Education at Columbia University, the hardworking Haley and Dr. Cecilia Sorensen, and Earth Medic Earthness, which I represent today. I would just like to reach out and say hi to our CEO and founder, Dr. James Hospitalis, who is all the way in the UK, and it's after midnight there. And of course, our hardworking Dr. Carrie-Ann Perth, who has been the lead of this seminar. Next slide. So our objectives for today would be to explain the risks and vulnerabilities at the intersection of climate change and cancer, and to discuss the root causes of climate and health vulnerabilities, and to identify actions individuals, providers, researchers, institutes, and communities can take. And here you see, in the next slide, our wonderful presenters, Dr. Leticia Nogueira, Dr. Marissa Nimrod, and Yvonne Alexander. Next slide. And so this is just to remind you that if you want CME credits, you must click on the link, which will appear after 1 hour in the chat, so that you can get your CME credits. Next slide. And we're going to have breakout discussion rooms. And in that, we're going to discuss, please, can you share screen again, Haley? Yes, we're going to discuss some of the environmental factors associated with cancer, some of the challenges that you're going to face, how we are going to decrease the carbon footprint, and the priorities for climate action, and how are these materials going to be used. Next slide. And so I'm going to introduce our speakers. Our first speaker is Dr. Leticia Nogueira. Dr. Leticia Nogueira, PhD, MPH, is a senior principal scientist at the Surveillance and Health Equity Science Department at the American Cancer Society. Dr. Nogueira's research focuses on cancer disparities that can be addressed by policy change, with a special focus on climate change and structural racism. She's currently the American Cancer Society representative at the Commission on Cancer Quality Improvement Committee, the Society of Behavioral Medicine Presidential Work Group on Climate Change and Health Disparities, the Medical Society of Consortium on Climate Change and Health, and the Oncologists United for Climate and Health, OUCH. Dr. Nogueira holds a doctoral degree from the University of Texas, Austin, a Master of Public Health from Harvard, an adjunct professor position at the Rollins School of Public Health, Emory University. She also received the Fellows Award for Research Excellence from the National Institute of Health in 2014, and in 2018, Doctor was inducted into the University of Texas College of Natural Sciences Hall of Honors, and in 2020, she received the Outstanding Young Alumni Award from the University of Texas. University of Texas. Welcome, Doctor. I'm going to read all the bios and then the speakers will start. So our next speaker will be Dr. Marissa Nimrod. She's currently the CEO of CAHU, which is the Caribbean Association for Hematology and Oncology. A physician by training, Dr. Nimrod graduated from the St. George's Medical University in 2010. She has a Master of Public Health with a specialty in global health. Dr. Nimrod has held many prestigious positions, including the president of the Trinidad and Tobago Medical Association from February 2022 to 23. She has been influential in steering the trajectory of cancer care, in Trinidad and Tobago and in the Caribbean through her leadership in many organizations, too numerous to mention. Dr. Nimrod is currently an independent consultant at PAHO. Her passion to improve the quality of life for cancer patients is the driving force for all her endeavors. Welcome, Dr. Nimrod. And then there is Yvonne Alexander, who is a retired police officer. She is the president of the Dominica Cancer Society. She's also a cancer survivor, and she's a lay associate in pastoral care. She advocates on matters of the elderly. Welcome, Yvonne. And so now we're going to hand over to Dr. Leticia Nogueira. Thank you.
Thank you. Thank you for the kind introduction. All right, let me know when you can see my slides.
Looks great.
Yeah, you able to hear me okay? All right. Climate change is the greatest threat to human health of our time. You've heard this before, and if when you hear this, you mainly think about future projections of rising sea levels or an increase in infectious diseases, think again. Climate change is already impacting the health of individuals across the world, and this is happening right now, and it's not necessarily about infectious diseases. Let me give you a few examples in the United States where I live and work. Climate change alters the behavior of extreme weather events. Warmer air holds more water vapor, which increases the water capacity of hurricanes. We can see this with Hurricane Harvey. This is a map from NOAA showing rainfall over Houston during Hurricane Harvey. NOAA had to add new colors to the legend because it had never rained so much in one spot before. Hurricane Harvey was when climate change and cancer collided for me. I was working at the Texas State Health Department at the time and was able to see firsthand the impact climate-driven disasters can have on communities, and especially among cancer patients for whom access to care is a matter of life or death. It wasn't the first time Houston had been impacted by a hurricane. The hospitals thought they were prepared. They all had backup generators, but Harvey was different. It stalled over Houston. Then it rained. Then it flooded. Then the backup generators flooded. Climate-driven disasters can damage medical infrastructure, break transportation links, disrupt supply chains, and interrupt cancer care even when they strike far from where care is being delivered. While we were working on the response to Harvey, Hurricane Maria hit and damaged several IV factories in Puerto Rico, leading to disruptions in medical care throughout the country. Harvey hit Houston on August 24, 2017. I joined the American Cancer Society on October 2017. The very first study I proposed after joining was to evaluate the impact of hurricanes on cancer patients. And when I did, people laughed. I'm telling you this because I don't want you to be discouraged when your project ideas that are based on your lived experiences aren't well received at first. It's okay, keep trying, keep pushing. It took a while, but eventually I was able to run the study and found, surprise, surprise, that patients who are impacted by a hurricane have worse overall survival. Not only that, but the longer that the hurricane disaster declaration lasted, which can be used as a proxy for how big of an impact that had in the community, the worse the overall survival. One question I frequently get when I present the results of the hurricane study is, well, yeah, but how many patients or how many facilities are being impacted by a hurricane? So this map is showing the healthcare facilities in the United States that were impacted by hurricane disasters between 2016 and 2020. These are, of course, highly populated areas in the United States with some of the largest cancer centers in the country. So many patients would be impacted. And we estimated that about 63% of facilities in the US were impacted by a hurricane disaster during those 5 years. Of course, hurricanes are just one type of extreme weather event. If we include other types, that number changes. 99% of healthcare facilities in the US were impacted by a disaster between those 5 years. So what can we do? There are several steps individuals, institutions, policymakers can take to better prepare for climate-driven disasters. We recently evaluated the type of emergency preparedness information that's available in cancer centers' websites in the United States, because these are distributed nationwide and are a trusted source of information in their communities. The first thing we noticed was that most websites provided some type of information about COVID, which was declared a national disaster in March 2020. Fewer cancer centers provided information on climate-driven disasters, which, as we just saw, have been impacting healthcare facilities since before March 2020. The majority of centers that provided any information had information on steps that the individual can take for COVID. And then for climate, the steps were like creating a portable medical card or pre-registering for a special needs shelter. But I would argue that putting the burden on the individual to prepare for an emergency might not be the best strategy. To be fair, some websites provided information on steps that the institutions were taking about COVID, and then about climate. The steps were things like consolidating appointments to minimize time spent outdoors during wildfires, for example. So there's an opportunity here for better information sharing that would continuously improve our adaptation efforts. Cancer centers, which usually have greater access to resources and have established collaborations with other healthcare facilities, are well positioned to become knowledge hubs for our adaptation efforts. And because cancer is not one disease, it's several diseases, each of which with associated comorbidities, information sharing from cancer centers' experiences can inform adaptation efforts for other medically vulnerable populations. The American Cancer Society's work is mainly focused in the United States, of course. We use data from the National Cancer Database. We link it with FEMA, but I worry about the gaps in knowledge from the experiences of other countries that are also impacted by climate-driven disasters, especially from the global south. Because beyond disruptions in access to care, individuals who have been diagnosed with cancer are a vulnerable population to the health hazards of climate change, due to the physical, psychological, and socioeconomic consequences of cancer diagnosis and treatment. The physical and psychological consequences listed here, for example, lead to increased sensitivity to the health hazards of climate change. Some cancer treatment drugs can inhibit thermoregulation, making individuals who have been diagnosed with cancer more vulnerable to heat waves and winter storms. A weakened immune system can make individuals more vulnerable to infections, which are common during flooding events. Cancer diagnosis and treatment also has socioeconomic consequences. Expenses that arise during cancer treatment and survivorship care, combined with changes in the ability of these individuals to remain employed during and after cancer treatment, are some of the ways cancer diagnosis is associated with increased financial hardship. And these socioeconomic consequences make it harder for individuals diagnosed with cancer to prepare and respond to disasters. It impacts their ability to evacuate or stockpile food, for example. It impacts their ability to adapt their housing infrastructure to cope with extreme weather events, such as improving insulation or using air conditioning during a heat wave, or installing special air filters during wildfires. And people are more than their cancer diagnosis. Different individual characteristics, including our racial and gender identity, the languages we speak, our socioeconomic status, all impact our vulnerability to the health hazards of climate change. Because there are no natural disasters, we make choices about where we inhabit, how we build, what type of research we prioritize, and these choices determine our exposure to natural hazards. Disasters happen at the intersection of exposure, hazard, and vulnerability. I would like to borrow the example used by Malcolm Ferdinand here in his book, The Colonial Ecology. The cover of the book displays this painting known as the slave ship. The painting is inspired by the true story of the ship Zong. The departure of the slave ship required substantial initial capital, so shareholders took out insurance. After a series of navigational errors that increased the journey time, Zong's crew decided it would be more profitable to throw enslaved individuals, still in chains, overboard, and file for insurance compensation, claiming the enslaved died as a result of an exceptional event, the approaching storm. However, the enslaved individuals were thrown overboard before the storm arrived, and this is what's centered in the painting. The storm is not the starting point of the disaster. The action of throwing people overboard to prioritize profits is the starting point. Disasters are not caused by natural events. Disasters are caused by human choices. Colonialism used violence to create hierarchical racial categorizations to justify slavery and establish the dominance of imperial powers over colonies through extraction, displacement, degradation, impoverishment. These colonial metrics of power persist to this day, with historically exploitative economies now being called developed countries, often with similar structures of domination, displacement, degradation, and impoverishment. For example, developed countries provide tax breaks and subsidies to extractive industries, which perpetuates environmental degradation in developing countries and supports an uneven flow of capital leading to poverty, vulnerability, and dependency on aid. And this is important because these discriminatory power structures impact all three pillars of vulnerability to climate change hazards: exposure, sensitivity, and adaptive capacity. Let's start with exposure. Polluting fossil fuel infrastructure, such as fracking, is usually located in communities targeted for marginalization, even within the United States, which is considered a developed country. In case you're not familiar with income inequality in the US, the darker the purple here, the higher the percentage of the population living in poverty, and you can see how it aligns with where the fracking wells are located. Environmental justice issues have been widely documented in the United States, where we know new fossil fuel infrastructure is usually developed in proximity to communities targeted for marginalization through structural racism. And proximity to fracking wells is an exposure hazard because piped natural gas must continuously be repressurized at compressor stations, which emit methane, fine particulate matter, benzene, formaldehyde, and other non-human carcinogens. Then there is the waste that flows back up the fracked well that also contains carcinogens and is deposited in injection wells that can then contaminate water sources. Proximity to fossil fuel infrastructure is a daily exposure hazard for these communities, but also an increased hazard during climate-driven disasters, such as what happened with Harvey in Houston. I'm using the example of proximity to fossil fuel infrastructure here for the exposure pillar, because a lot of times people ask me if climate change increases cancer risk. And we usually have a conversation about increased exposure to UV radiation, for example, or the inability to exercise outdoors due to increased higher temperatures and all different types of future projections. And all of these are important. However, it is also important to realize that we do not need future projections to recognize the link between climate change and increased cancer risk, because our reliance on fossil fuel is a shared cause of climate change and an increasing exposure to carcinogens. When you start thinking about it like this, one of the first examples that might come to mind is lung cancer and air pollution from vehicle emissions. The same air pollution that's driving the greenhouse effect also increases lung cancer risk. However, extracting, processing, transportation, and waste management of fossil fuels releases many carcinogens in the environment before and after they are consumed. And these are the examples I'll be using to talk about exposure hazards associated with climate change and cancer risk. After exposure, there is sensitivity, which is the degree to which climate hazards impact humans. And we already talked about the physical and psychological consequences of cancer diagnosis and treatment, and other chronic health conditions are also important here. Individuals with diabetes need to be able to keep their medicine refrigerated. Individuals with chronic kidney disease are more sensitive to heat waves. And here again, due to barriers in access to health resources and increased exposure to health hazards, communities targeted for marginalization have the highest prevalence of chronic health conditions such as kidney disease, which will increase sensitivity to heat waves. And there is adaptive capacity, which is the ability to cope with climate hazards. And we already saw how limited access to resources can reduce the adaptive capacity of individuals and communities with the example of financial hardship among cancer patients. And current power structures make it difficult for communities at the front lines to access the necessary resources to rebuild after climate-driven disasters or to reinforce infrastructure before the next disaster strikes, as highlighted recently by leadership in Barbados. And here's the thing about frontline communities. A lot of times when you're closer to the problem, you're closer to the solution. Yes, it is true that frontline communities are impacted first and worse by the hazards of climate change, but nobody's safe. Let me give you an example. Wildfires in the United States. Wildfire activity, which is closely tied to temperature and drought, is increasing significantly with climate change, no matter how you measure it, by area burned, by number of large fires, by fire season length. And wildfires are more likely to occur in the wild and urban interface, or the suburbs, which have also been growing since the 1990s, no matter how you measure it, by area, by housing unit, by population, and they're depicted in orange here. So this leads to an increase in exposure to wildfire. We are currently using NASA satellite data to evaluate the impact of proximity to wildfires and survival among lung cancer patients. I mentioned the satellite data because the United States has an air quality monitoring network that can provide real-time data on air pollution. However, these air quality monitors are located in metropolitan areas, and as we saw, wildfires are more likely to occur in suburban areas. Also, proximity to wildfire goes beyond exposure to air pollution. Even if the smoke plume is blowing the other way, being close to a wildfire can increase stress that's associated with having to evacuate, or threat to your property, threat to your life, can disrupt your access to your healthcare provider. Another important point about using satellite data and how it allows us to evaluate exposure in suburban areas is that in the United States, this is where high-income individuals live. So the rich are actually more likely to be exposed. Allow me to be a nerd for a second and mention that in such studies, the methods you choose are extremely important because, for example, after surgery, individuals have to survive long enough to be exposed to a wildfire, and then we can evaluate how exposure to the wildfire impacts long-term survival. In this study, we used inverse probability weighting to account for mortal time bias because the exposed individuals had guaranteed survival between the time when they were discharged from the hospital and the date when they were exposed. And we did see that exposed individuals have worse overall survival. So again, it is true that communities targeted for marginalization suffer first and most from the health threats of climate change, but nobody is safe. And it's exactly because frontline communities suffer first and worst that we need to include these neglected voices in the conversation, that we need to invest in amplifying climate change knowledge coming from these communities. And this goes beyond knowledge about the detrimental health consequences, and it has to include the solutions they are identifying in these communities. There are several examples of individuals from these communities leading the resistance to the development of new fossil fuel infrastructure, which we now know benefits the entire population. And before I finish, I just wanted to mention one more thing. The healthcare system is the second most energy intensive in the United States. Emissions from the US healthcare system alone exceed emissions for the entire United Kingdom. Increasing use of clean energy sources, especially those that are generated on site, can reduce the environmental impact of institutions and also make them more resilient to power outages. They're only expected to become more frequent with climate change. The healthcare system also purchases significant amounts of food and can decrease its environmental impact by seeking environmentally responsible food manufacturing, shipment, and waste options. Also, meat from ruminants has the highest environmental impact, no matter how you measure it, per unit weight, per serving, per unit of energy, per protein weight. If you consider the emissions associated with the production, processing, and transportation of feed, the methane emissions by the ruminants, the energy consumption at the feedlots, the amount of antibiotics and pesticides used, the amount of waste generated, then it's easy to understand why the environmental impact of meat production is so significant. And if that wasn't enough, red meat consumption is associated with increased colorectal cancer risk. There are several other steps that institutions can take to decrease their environmental impact. And if you're looking at this list and thinking, this lady is crazy, there is no way my institution would do anything. Let me ask you something. Are you allowed to smoke on campus? How do you think that happened? How do you think it started? I know this is all very overwhelming. There's so much to do in so little time. And the way I try to organize my efforts, it goes back to John Holdren saying that we have three choices with climate change: mitigation, adaptation, and suffering. The more mitigation we do, the less adaptation would be necessary and the less suffering there will be. So we can support sustainability efforts at our institutions. We can engage in the development of coordinated and equitable emergency preparedness efforts. Of course, none of us wants to contribute to suffering, but we can document the suffering that's already happening and help increase awareness of the impact of climate change on cancer and health in general to incentivize action. And if you're attending this talk, you most certainly have the power to make a difference. Recognize where your points of influence are. Use your leverage. Move the world. Thank you.
So I would like to thank Dr. Leticia Nogueira for that very inspiring talk and helping us to understand the importance of developing emergency plans and the impacts on the vulnerable and the intersection between exposure, hazards, and vulnerability, and pointing out to us sometimes where we need to do the studies are in the vulnerable population, but that is not happening. It's in the well-to-do areas. So we need to begin to look at that. And if we want to help our patients and not suffer, we need to look at adaptation and mitigation strategies. Now, I did a great injustice to my audience because I did not welcome them. And worse yet, I did not introduce myself. So my name is Dr. Paula Henry, and I would be the moderator for this session. So again, we thank Dr. Leticia for her wonderful presentation that inspired us all. And so we're going to move on to our next presenter, who's Dr. Nimrod, who's going to tell us a little bit more about cancer, climate change, and cancer. Thank you, Dr. Nimrod.
Thank you very much, Dr. Paula Henry, and good evening, everyone. Thank you very much, Dr. Nogueira, for such an interesting presentation. Allow me to just bring my PowerPoint up. Okay. Okay, can everyone see my screen? Can you hear me as well?
We can see it now.
Okay, no problem. All right, so good evening. So my name is Dr. Marissa Nimrod, and I represent the Caribbean Association for Oncology and Hematology. My presentation follows on quite a few points that were iterated before. So we're just going to focus this evening on lung cancer and skin cancer and how climate change impacts as risk factors for both cancer types in the Caribbean. So cancer is the second leading cause of death globally after cardiovascular disease. And we know to date, as identified before, that climate change has an impact on chronic diseases, including cancer. So environmental exposure that are risk factors for cancer include ultraviolet rays, air pollution, and environmental toxicants. So we're going to look
Sorry,
at
Dr. Nimrod, just before you continue, you're not in the slideshow format, so we're seeing everything.
Oh, okay. Sorry.
The slides on the side and that. Yeah, just to let you know.
Hold on. Sure. Hold on. No. Okay, Haley, can I get your help then?
Dr. Nimrod, in the bottom toolbar on the right, there's a little notification. It's like a square with sort of like a T shape at the bottom. If you click that, you'll be in presenter mode. Or you're on mute.
Just go all the way to the right.
You can click slideshow as well, And then from current slide. There you go. Brilliant.
Sorry, my dog was actually barking, so I put it on mute. Apologies. Sorry, can you hear me now?
Yes.
Okay, good. Okay, probably I should assign privileges to hearing. Okay. All right, so we're looking at the Sustainable Development Goals, and the top three that we're going to focus on would be having sustainable cities and communities that actually reduce the emissions and contributions towards air pollution, for example, for lung cancer, and to make sure that we have both good health and well-being as per the SDG 3 goal. And 13 actually focuses on the goal that we're discussing tonight, which is climate action. So in terms of climate change, we have at least 4 variables that can impact the same. And we look at tobacco, which has a direct link to the development of cancer, not just lung cancer, but also cardiovascular, respiratory diseases, and then the production of the greenhouse gases. We also know that transportation, which is another important social determinant in terms of moving, can affect air pollution, increase your risk for cancer, and the same as identify cardiovascular and respiratory diseases. Okay. All right, so we're looking at climate change variables, and this particular figure shows potential associations between risk factors and the development of cancer. If we look at lung cancer in particular, which is the third one down, we can see ambient air and pollution of ambient air, household air pollution, including radon, and this month is actually radon gas awareness for CDC, and also wildfires, as discussed before, and the particulate matter are risk factors for the development of lung cancer. And skin cancer, which is the third from the bottom, would also be assigned as having ultraviolet rays or radiation as a risk factor for the development of skin cancer. So we're going to look at the sun in particular and skin cancer. So we know that the loss of the ozone layer due to the production of chlorofluorocarbons, referred to as CFCs, actually is one of the reasons why we have the particular UVB rays, ultraviolet B rays, which are the harmful ones that are actually penetrating even in a higher concentration because of the loss of certain areas of the ozone layer. These CFCs are released from solvents, spray aerosols, refrigerators, air conditioners, etc. So why is ozone important? Ozone is a molecule that absorbs all levels of ultraviolet radiation. The molecules of the chlorofluorocarbons are broken down by UV radiation. They release the chlorine atoms, and then these atoms react with the ozone and destroy it, which, as we said, allows for the harmful UVB rays in particular to increase your risk of skin cancer. So just looking really quickly at this particular infogram, we can see that UVA rays are going to penetrate the epidermis. It can get as far down as to the dermis. But as we move across the slide, we can see the UVB rays coupled with the UVA can cause DNA damage. And this can actually set off that carcinogenic or DNA damage, which increases the development of 2 types of skin cancer. The first one we're looking at is the basal cell carcinoma. And as we can see from this slide, it usually occurs in sun-exposed areas of your body, such as normally your neck or your face. The appearance, as we can see from the image from Mayo Clinic, it can appear as either a pearly or waxy bump on a patient. It's a flat flesh-colored and sometimes brown scar-like lesion, and sometimes it bleeds and it can scab, but it doesn't heal. With that being said, such patients are going to be referred to a dermatologist for additional investigation. The second type of skin cancer that develops is the squamous cell carcinoma, and this is the second most common human cancer in terms of dermatology. Again, it's going to arise on sun-exposed skin or lips, and it can appear as pink or red or sometimes dark roots or bumps. In this case, in this patient is presenting on the forehead or the sun-exposed area on the scalp. This can actually present in locally destructive lesions, and if it is not actually screened and attended to early, can be fatal. 90% or greater cure rate can be achieved if patients actually present and have it managed early. So what we can do to do the prevention of ozone depletion, because in public health, prevention is a big part of what we do. We want to reduce the use of ozone depleting substances as identified before, minimizing the use of vehicles that emit carcinogenic substances from our hydrocarbons. We can carpool where possible, use of eco-friendly cleaning products, and then obviously, importantly, the creation and implementation of policies that would reduce harmful emissions in industry. Prevention for persons would include use of protective clothing, using long sleeve shirts, pants, etc., application of sunscreen. So when you go out, some persons have the ability to look to see what the UV index is on a particular day. And if it's 3 or greater, you'd want to apply a sunscreen with a SPF of 15 or higher. And then most importantly, if you're smoking, you want to quit smoking. So I'm not going, this is a very complex diagram, but this was discussed previously with respect to lung cancer and air pollution. So in essence, it looks at fossil fuel combustion, as noted before, which contributes to pollution of your ambient air. And we can actually see the PM, which is your particulate matter. We have nitrous oxide, we have volatile organic substances, lead, etc. And these, at the end of the day, as we can see, can lead to lung cancer development. So lung cancer is the leading cause of death in the US and the Caribbean, which is something that's important and we should be cognizant of. Air pollution can affect respiratory health of our patients, resulting in asthma and chronic obstructive pulmonary disease or COPD exacerbations. Lung cancer incidence and mortality has been elevated in subjects more heavily exposed areas in terms of ambient areas, and also in probably to a lesser degree with respect to household air pollution. We know that smoking is a leading cause of lung cancer and a contributor to carcinogenesis, and as we noted before, radon as well, which is accumulated in any building, which can also be including our homes. In particular, with respect to the ambient air, we're looking at PM 2.5. So that inhalation of particulate matter 2.5 in terms of diameter has been affiliated or associated in studies in the past to show an increased risk. And this is evident in countries like China, where they actually have increased pollution because of the production and the combustion of carbon substances. So in terms of presentation for lung cancer for patients, we can see that it can present as this nagging cough. So it's a new cough that doesn't go away. Some patients may actually cough up blood, even a small amount, which is referred to hemoptysis. They experience shortness of breath, sometimes on exertion and at rest, chest pain, hoarseness, weight loss, without actually having a schedule in terms of trying to lose weight, bone pain if there's metastatic disease, and if it gets to the brain, they can present with headaches. So how do we actually prevent lung cancer in terms of environmental? So we can use appropriate level of PPE or personal protection, so using the face mask and hand hygiene. There's always modifiable lifestyle factors which can be addressed in terms of smoking cessation, exercise, and then also keeping up to date on your local air pollution levels. As said, so you can look on the phone and Google to see exactly what is that indicator in that area which you intend to go or where you live. And then
she started telling us about the different risk factors for cancers, the different types of cancers, and what we can do to decrease the fluorohydrocarbons in the atmosphere, and so decrease the hole in the ozone layer to prevent ourselves from getting damage to cancer. And then she went on to tell us a little bit more about the risk factors and how we could prevent those to decrease our impact of cancer. So Doc, we know that you're having internet challenges, but we'd like to thank you for giving us that very informative presentation. And so I would like to bring on our next speaker, who is Yvonne Alexander, who's going to share a little bit about her case history. Welcome, Yvonne.
All right, good night, everyone. Thank you, Dr. Paula. And well, I was already introduced. So by way of introduction, I am the president of the Dominica Cancer Society. And I just want to really speak a little bit about the Dominica Cancer Society. We are a not-for-profit organization. We are funded through a subvention from the government of Dominica that allows us to meet the cost of our rental of our office space and the payment of utilities and some of our admin costs. We are, very limited staff. Our mission is to empower families, individuals, communities through education, advocacy, and the mobilization of resources for the promotion of prevention, early intervention, effective diagnosis, and quality treatment for improved quality of life for individuals affected by cancer. Our vision is to be a beacon of hope, help, and support. We undertake our mission through three main areas of focus. We mobilize financial resources so that we can assist individuals in need to meet the cost of cancer treatment. We do that through fundraising activities. We solicit donations from individuals and businesses. We do a lot of educating and advocating about cancer prevention, treatment, and care. We do so through monthly radio programs. We participate in health fairs. We do community engagements. We do social media. We provide psychosocial support for individuals and families, and we do that through our support groups. We also have a hospital support team which accompanies individuals who are diagnosed through treatment. In terms of the impact of climate change, in September 2017, Category 5 Hurricane Maria devastated my island home, Dominica. In that year, I was newly elected as the president of the Dominica Cancer Society. I was also newly diagnosed with cancer. At the time, the Dominica Cancer Society office, which was also referred to as a wellness center, contained the spare bedroom, kitchen, bathroom facilities, which would be made available for use to anyone from the rural communities who needed to rest for a day or two after receiving treatment. The building and its contents were completely destroyed during the passage of the hurricane. The building was rented and was covered by insurance. So too were our contents. However, that particular insurance company declared bankruptcy, and so we lost everything. In terms of the experiences of members, our members were affected like everyone else. Some lost their homes. The homes were completely destroyed. The homes of many others were extensively damaged. Many homes were flooded, resulting in damages to furniture, appliances, and personal effects. Some were able to rebuild or repair, and others are still recovering and are traumatized every hurricane season. Owing to the wide-scale destruction, many members were displaced. Some moved to other addresses. Some migrated. Also, some lost their jobs due to the widespread destruction to many businesses.
Okay, Yvonne, I don't want to cut you, but you have 1 more minute, okay?
Cancer treatment was disrupted owing to the damage to the hospital and the flooding of the oncology unit. It was a few months before arrangement was made to resume treatment. I'm aware of a few patients who subsequently succumbed to their illness within months of the passage of the hurricane. In terms of other challenges, there was the disruption of the food supply chain and the difficulty in finding the right foods to eat as a result of the extensive destruction. Many of us resorted to canned goods, which was not necessarily the best option. We had difficulty in locating our members, but we were able to do so at some stage. And one of the first things we did was to arrange a meeting with a guest speaker who was a psychologist, and she was able to allow members to speak and to be heard about their experiences. We were also, through our networking, able to obtain supplies for some of our members, and were able to assist those in most need. We were able to provide such things as basic food supplies, prostheses for breast cancer survivors, and the likes. Through a small grant, we were able to purchase some basic office equipment, and we were able to get back into business. One of the learning points is the fact that we were at the time very centralized. And because of that, there was difficulty in trying to reach all our members following the devastation of the hurricane. We were able to do so through radio announcements at some stage. Before I end, I would like to allow you to listen to a very short video clip. It's just about 2 minutes.
Okay, so
from
here what?
somebody,
Wait,
from a
here
member
what-
who was
Wait. So here what's going on. Wait. Yvonne, give us a minute. We will come back to listen to the videotape if we have time, because we still have 2 other presenters and we have breakout rooms. So we're going to try to come back and listen to the videotape. Otherwise, we would run out of time, okay? So just give us a moment. Let the other 2 presenters present, and we hope that we could come back, okay?
All right. Thank you very much
thanks.
for listening.
Okay, thanks.
All the best. Yes.
Okay, thanks. Okay. Thank you for sharing with us all that tribulation. And now we're going to have the first group. And who will be presenting for that group? Is it Yuvashti, or is it Kessling, or is it Simone? Simone. Okay, Simone, go ahead.
All right, good afternoon, everyone. Just 1 sec, I need to shift my screens a sec. There we go. All right, so good afternoon, everyone. I hope you can hear me clearly. So my name is Dr. Simone Charles, and it's my pleasure to present today. So I would like to say thank you for the informative presentations. Our working groups take the type of information mentioned during the presentation and develop what we think. Right, are you able to see my slide? Okay, great. All right. So we take the kind of information or the type of information mentioned during the presentation, and we develop what we think suitable for communicating that information to various groups. So for our working group 1, we focused on information communities and patients should know in a format potentially helpful for agencies to utilize in their climate action. So we created a standing poster that focused on 3 main categories of information. So the first one is the negative impact of climate change, such that climate change increases environmental exposures, such as air pollution, UV radiation, increases your exposure to air, water, and soil toxicants, a prevalence of infectious agents, and so on, as you heard earlier. We wanted to focus on climate change increases systems disruption, such as the food and water supply disruption, transportation and communication, and healthcare system disruption, as well as disruption of the cancer care continuum. And then health disparities increases, such as stress and mental health challenges, increased infection, and disruption to cancer care access and delivery, and of course, the loss of the maintenance of healthy behaviors. Secondly, we wanted to focus on how can one limit their exposures and implement prevention strategies or actions, such as dietary changes, physical activity, sun protection, and reducing risky behaviors, as well as, of course, societal policy changes. And the third type of information we thought was important was personal or community level climate action, such as advocating for strengthening the healthcare system to ensure that the healthcare system is resilient and has emergency preparedness plans. And then personal or community level climate action, reducing your personal carbon footprint, advocating for the healthcare system's reduced carbon footprint, and then seeking cancer prevention services early, and of course, mitigating exposures. So with these three categories of information, we created a standing poster with this information in an easy to read and visually appealing product. So thank you for your attention.
Thank you very much, Dr. Charles, for that very informative and, of course, very graphic poster that should be used many areas, and we thank you for that. Now we have Dasev Bryce, Dr. Dasev Bryce, who is from Work Group 2, and she will be giving us the second presentation. Welcome, Dasev.
Okay, try to unmute myself. Okay. Freezing. Did something happen?
Not yet, we're not seeing anything.
Okay, I tried to share my screen.
Okay, let's try again.
I hope everyone can see my screen.
Yep, you can put it in
Yes,
presentation mode.
perfectly. Mm-hmm.
Good afternoon, everyone. My name is Dasev Bryce. I'm from Haiti, and I represent the working group 2 of Orthopedic Earth Nurse. And tonight, we're gonna present you an educational material we developed for healthcare workers to adapt in their practice about a case history related to air pollution, which is one of the consequences of climate change linked to disaster impact. The objective of this educational material is to address the question related to the symptom a patient can present when develop some climate change condition, some clinical condition related to climate change, to identify occupation and environmental exposure related to his living condition. And also, this educational material will help the healthcare professional to develop some type, to identify the type of exposure to air pollution and the ambient air pollution linked to cancer. And the last point, we will show how the disruption factors can be a consequences on all climate disaster affect the healthcare facility, and that can make difficult to have access and availability in the services. Now we will like to invite you to watch this case history of Maria. We would like to thank you for watching this video, and keep in mind this history can be a history from your member of your community, a neighborhood, colleague, or friend. Thank you for watching. Yeah, thank you for watching this educational material. Back to the content. So, talking point about this presentation. We address the outdoor air pollution from industrial and manufacturing, and also the agricultural emission. Also the indoor emission from the household combustion of coal and biomass fuel. And we also addressed the point about the lung cancer. That was the suspicion diagnosis of Maria, and the description problem and inequity in low middle income country that our country knows related to climate change and cancer. We also address the clinical investigation, and the factor for discussion is the less accessibility in case of disaster, availability of service is absent, and the distribution problem in case of emergency. And we also address inequities in low middle income countries and all the impact climate change and cancer can have on the community. So there are some resources we share with you for developing this material. And we want to acknowledge all the members of the group that contribute to this work. And thank you for watching this video. We will discuss more about the material on the breakout room. Thank you.
Okay, thank you for a very innovative type of presentation, Desiree. That was indeed very interesting. Okay, so now we are going to go to the breakout rooms and we will discuss the questions. How many breakout rooms are we intending to have, Haley?
We're going to have 8 breakout rooms, and I'm going to drop the prompts in the chat right now for everyone to reference.
Okay, so you would roughly have about 15 to 16 minutes before we come back. And when we come back, we will be able to take 1 or 2 or 3 people who could summarize what their group said. We may not have time to do more than that. Okay. You just have 1 minute. You unmute Vashti.
Nada.
Okay,
what
Vashti.
our healthcare facilities we're doing to help with the, researching your healthcare facility. And
so wait, what question are you answering? What question are you answering?
We had a lot of discussion on others, but for the essence of time, we're going to do number 4.
Okay, go ahead.
Okay. My partner here, I didn't get her first name, Hers. She's an educator and she's doing a lot in her facilities and educating healthcare professionals how best to use oxygen, what about medical waste, how they can harness energy. And in my facility, we've done a whole lot of things to do. We have buildings that are powered by solar energy. We have to recycle. We cannot just throw things away. It has to be repurposed. And we've saved a lot of money. So it's cost effective. And if you do that, we then in turn need to teach our patients to do that. So it's the ripple effect and the community around where we live and work will become safer. So I don't want to take up too much time. I want somebody else to go.
Okay, yes. So thanks a lot for that, Vashti. I very much appreciate that. Okay, can we
Thank
have this another sharing, please? Sheila, you want to share? Just give us a summary of what your group spoke about, what question you were trying to answer. Yeah, you can go ahead, Sheila.
I was in with Vashti.
Vashti.
Oh, okay. So we need someone else, please.
Yeah.
And I just
and
shared
so
her
she just
thoughts.
presented, she asked me if I wanted to present, but I couldn't get in there fast enough. She summarized it wonderfully.
Thank you.
Okay. Anyone else? Patricia, you want to share what your group shared? Okay, so I just want to say maybe what my group shared. Somebody spoke about the use of pesticides and the volatile. We were talking about environmental factors, and they spoke about the use of pesticides and how volatile organic compounds were released. Somebody talked about air pollution because in their country, there's a cement factory and also there's the mining of bauxite. And somebody spoke about the burning of coal and wood in the rural areas. And a lot of time the garbage trucks do not come. So people burn a lot of their garbage and that causes a lot of pollution. Okay, so I think we're kind of running out to the
Can I
end of
say
time.
something? Can I
Sure,
say
Vashti.
something before?
Okay, yes,
Can
Vashti.
I write up and send it to you of what we talked about? Because I would hate my colleagues' work not to be credited.
Okay, thank you. And we want to do some research
And
and
I
we
will-
want to hear from everyone.
Yeah, I'll put my email in the thing. You can, if anybody wants to send notes, please send them to me. And I'll put the email in the chat now. Thank you, Vashti.
You're welcome.
Okay, so we are coming to the end of our session. And I would like to thank our presenters, Dr. Leticia Nogueira, for entertaining us. Okay, so Haley's putting up a hand. Did you put the CMEs in the chat, Haley?
Yes, yeah, the link is there now.
Okay, so if you want CMEs, please fill out the link. And we want to thank Dr. Nimrod, who I think dropped off. And we want to thank Yvonne Alexander and the work group chairs. And of course, everyone who contributed to the various breakout groups and sharing with us. And so please join us next month. It's the 4th Thursday, and we are going to be talking about climate change and respiratory diseases. It promises to be exciting. So unless we have nothing else to say, I think we'll have to say our goodbyes for now. Thank you, Haley, for such a great job. And I would like to thank my team again, Dr. Hospitalis and Dr. Carrie-Ann Pert, the group leader who has led us so well in this series. Okay, our time is up. Bye, guys. See you next month.
Thank you.
Okay, bye-bye.